I get asked a lot why people get inflammatory bowel disease, and there's not one completely true, simple, straightforward answer. The truth is just human beings are so complicated, and there are a lot of things that combine to answer this question. But I can say there are over 200 different genetic loci or different bits that have identified as being associated with inflammatory bowel disease. Every once in a while, we get what's called a monogenic IBD, where just one single little genetic change can cause IBD to happen. And usually when that happens, it starts under 6 years old and it's very severe and hard to control. But usually it's not like that. It's a combination of multiple genes all working together to change the way we're inflamed in the way we produce mucin and a bunch of other things. And that all adds up to be a picture we call IBD. How much does genetics change risk for IBD? Well, it's important, but it's definitely not the only thing. If you have ulcerative colitis, there's only a 10 to 15% chance that your identical twin will. And if you have Crohn's, there's a 30 to 50% chance your identical twin will. So more important genetic contribution from Crohn's, but still not making up the whole story. There are other things based on your environment and what triggers you experience and what's going on with your microbiome and what foods you're exposed to and other things that contribute to the answer of do you actually get IBD? So genes are important, but they're not the whole story. So what is it that these altered genes are encoding for? They're changing things to do with the innate immune function, with cytokine production, and that's one of your vocab words if you watch that section, to do with immune tolerance, mucin production, barrier integrity, tissue repair, and I want to spend a few slides talking about what I mean when I say innate immune function. So the immune system has two major branches, the innate and adaptive immune system. The innate immune system defends against pathogens in general without recognizing a specific pathogen. So mucin, or the mucus that is naturally produced by our goblet cells, that's an example of like an innate immune function. Sometimes I use this analogy of the human and the human immune system is like a castle, and mucin is just like the moat around the castle, defending it against everything in general with not recognizing it. Another one is these antimicrobial peptides produced by Paneth cells. These are produced deep in the basest crypts of your intestines, which is where stem cells are located, and we really want to protect our stem cells from any bad guys. So these Paneth cells near the stem cells produce these antimicrobial peptides in general just to keep microbes out. In contrast, your adaptive immune system centers around T cells and B cells. And these are the immune cells in your body that have this amazing ability to identify and recognize and adapt to specific pathogens. T cells attack pathogens directly most of the time, and B cells are what produce antibodies. Nothing else produces antibodies. B cells are the only ones. So when you have IBD, parts of your immune system, especially the innate immune system, might underfunction. Like for some people, they have genetic MUC2 abnormalities, and their goblet cells don't produce enough mucin. And for other people, there's what we call pattern recognition cells, which aren't recognizing pathogens. So the Paneth cells don't produce enough antimicrobial peptides. That's because of genetic NOD2 abnormalities, more common in Crohn's. And in terms of the adaptive immune system, sometimes we have these T cells called regulatory T cells or Tregs. So when they're underactive, they can't calm down the immune system enough. And that's when we have genetic FOXP3 or other types of genetic abnormalities. So sometimes we have under-functioning parts of the immune system. And so kind of to compensate for that, sometimes parts of the immune system over-function. One example is neutrophils. I think I have a highlight here. So in the normally functioning immune system, you're bringing in neutrophils into tissues, from blood vessels into tissues. And they produce these things called NETs, neutrophilic extracellular traps, which are kind of trapping things and increasing exposure to microbes. So if you have too many nets around, then you have your immune system exposed to microbes for longer, which for certain types of immune systems can really irritate things if those nets are keeping things around too long. And with the adaptive immune system, sometimes you have increased inflammatory cytokines recruiting more of our adaptive immune system and making more T cell and B cell activity. And some of our tests to help us understand and diagnose ulcerative colitis and Crohn's in the first place, these are all about antibodies, which are produced by our B cells. So sometimes we can really see overactive B cell activities by if we have certain antibodies showing up. So why would we get it? Like, are there advantages? Could there have been advantages in the past to people having immune systems that function this way? Yeah. So in some times in history, in some areas of the world, our ancestors were constantly exposed to certain types of pathogenic microbes. Some important ones for people with IBD genes are mycobacteria, like Mycobacterium tuberculosis causes tuberculosis, or Mycobacterium leprae causes leprosy, or Candida, which is a fungus. Sometimes our ancestors were exposed to these so much that if our immune system was inflamed all the time, that would be harmful to us. It's like they're around all the time. We can't be inflamed all the time or it's just going to hurt us. So the innate immune system evolved to downregulate, and the adaptive immune system upregulated in order to compensate. And at that time, with pathogenic microbes around all the time, this was an advantage. I have this analogy. Bear with me here. I had an AI model help make me some pictures here, and maybe this will help. So here we have our immune system, and we've got like our mucin, which is our moat around the castle. We've got our epithelial cells, which are like the door keeping the castle shut. And we have watchmen in general, which are maybe kind of like our neutrophils. That part's not that important. And so there's traffic in and out of the castle all the time, right? And say we have bakers coming in. And in lots of these bakers, which are like microbes we're being exposed to, lots of them are happy and they're benefiting us. They're actually bringing bread into the castle. But sometimes we get some bad bakers and they make some bad bread that people hate the taste of, or it's even making people sick. So those are the bad bakers. And that is the job of our immune system, is to keep those pathogens, those bad bakers out of our system. And in a world of the past where there are tons of microbes everywhere all the time, including unfriendly microbes, bad bakers, we have to have a team of guards, this is the adaptive immune system, inside the castle interrogating these large groups of people that get through, because there are so many of them. So in modern times, there are way fewer exposure to microbes of all kinds, including pathogenic microbes. So you only have a few bakers coming through, and most of them are friendly. We're not exposed to that many pathogens anymore. And in addition, with this world that we live in, where we're exposed to a lot of antibiotics and proton pump inhibitors and microplastics and pesticides and herbicides, all these things can harm our ability of our body to produce mucin. It can harm our mucosal integrity, and it can even cut down on the ability of our neutrophils to do what they're supposed to normally do. And some of us, some people with IBD, have also evolved genetics that make these things less active as well. So it depends on the adaptive immune system. These things have got to be even more active. But when you've got an overactive adaptive immune system and only a few bakers around, most of whom are friendly, you end up putting friendly bakers in the stocks and causing harm to our friendly bacteria. And that actually ends up causing harm to the tissues all around. And it's like setting the bakery on fire because the adaptive immune system is too active, causes harm to our basic tissue, and it's like burning down the castle from the inside when IBD is at its most severe and its most active. So that's my kind of complicated analogy about why we get IBD. So how do we use this knowledge of immunology to look for solutions? Well, in the broad sense, there's a few ways, like thinking about how our immune system could have been matched to a different situation. Well, if we move to a place with lots of exposure to pathogenic mycobacterium, like places where tuberculosis and leprosy is very active, well, that could maybe help. That's the hygiene hypothesis. The original hygiene hypothesis said if only our immune systems were exposed to lots of pathogenic microbes, we wouldn't get so much autoimmune disease. Well, there's a more modern version which says, well, maybe if you expose yourself as a child and your mom while she was pregnant to a variety of diverse but harmless microbes, that could stimulate healthy immunity too. Just give your special crew inside the castle more practice at telling healthy microbes from unhealthy microbes by having exposure to farm animals and probiotics and fermented foods and that kind of things. That's called the old friends hypothesis, saying there are certain non-harmful microbes, including helminths, which I'll talk about at length in a later module, that can actually stimulate healthy immunity. But at this point, if you have IBD, it is too late to go back and expose yourself as a child or your mom while she was pregnant to a bunch of microbes. So how do we try to help people with IBD? Well, in conventional medicine, the conventional medical approach is reduce inflammation with drugs and cut out the inflamed gastrointestinal tract as needed. We use drugs to reduce inflammation and we use surgery as needed. That's the conventional medical approach. But for me, I think the best balance for somebody who has IBD is use informed trial and error to choose therapies having to do with microbes and diet, herbs, supplements, helminths, and lifestyle, and use drugs and surgery where needed. And that is our approach here at Foundational Medicine. So we really aim to have the best of all worlds of what we're pulling from conventional medicine, drug therapy, referring to our colleagues in surgery when needed, and also using all of these ideas to really inform how we are treating people. And more specifically, your naturopathic doctor and your conventional doctors are always kind of trying to target some of this immunology more specifically. We're thinking about, are your goblet cells producing enough mucin? And if not, maybe we're using mucilaginous herbs like Dr. Bustamante talks about in the botanical medicine and herbal section. Are your Paneth cells producing enough antimicrobial peptides? Are you having enough short-chain fatty acids? I'll talk about fish oil in the supplement section. What's going on with tissue damage? Do we need to use herbs or supplements or other things to enhance tissue repair? What's going on with your neutrophils? There's certain drugs that actually affect the way that neutrophils leave the bloodstream and go into tissues, and those are drugs that are worth thinking about sometimes. What sort of antigens are hanging out in the lumen of your gut, and do we have to think about decreasing those antigens so as to not aggravate your immune system? So we're always thinking about immunology in terms of how we guide your interventions. TNF-alpha, this is some of the most important drugs. The earliest biologics for IBD are all about targeting TNF-alpha, and so that's something we're thinking about as well. Do you or do you not have elevated TNF-alpha? So immunology can guide therapy.